Right. Welcome everyone to the ECHO COVID-19 Global Learning Collaborative. I'm Matt Bouchonville. I'm one of the associate directors at Project ECHO in New Mexico. Thank you very much everyone for joining us today. We are joined again today by Dr. Soumya Swaminathan, Chief Scientist of the World Health Organization, and she will be leading a panel discussion in collaboration with the world's experts on what we have learned about the clinical management of COVID-19 patients. And before we get started, I want to alert the network that we have Spanish and French interpretation services available. So you can follow the conversation through an interpreter if you wish. Additionally, for the question and answer portion of today's session, you will be able to submit your questions in Spanish or French, and the interpreters will interpret those questions to English to the speakers for you. And just to review, if you're new to this, you can look to the bottom of your Zoom screen and you will see a globe icon which says interpretation. And if you click on that interpretation icon, that'll pull up options of either Spanish or French, and you can click on your preferred language, and then you'll have the option to hear only the interpreter or to keep the English softly in the background as well. So thank you to our interpreters for joining us today as well. We have had almost 2,000 registrants for today's session, and we're grateful for the time that you've taken out of your busy schedules to join us. I'll be assisting and handling the questions that are submitted by the network today in collaboration with the director and founder of Project ECHO, Dr. Sanjeev Arora. Sanjeev?
Hi, welcome to all of you. I want to especially thank Dr. Swaminathan, who's the Chief Scientist of the World Health Organization, who has agreed to lead this global conversation series to share best practices from around the world. And my name is Sanjeev Arora, and I serve as the director of the ECHO Institute at the University of New Mexico. And welcome to all of you.
Thank you, Sanjeev. And let's continue with a round of introductions, beginning with the moderator for today's session, Dr. Soumya Swaminathan, Chief Scientist of the World Health Organization. Dr. Swaminathan?
Yes, hello everyone. Thanks for joining the webinar today. This is the second in the series that we're doing with ECHO, and we'll be talking about clinical management and what we've learned, and we've got an excellent panel that we've assembled from around the world. Thank you all.
Thank you, Dr. Swaminathan. How about from our expert panelists, starting with Dr. Maurizio Cecconi?
Hello, everyone. I'm Maurizio Cecconi from Humanitas Research Hospital and Humanitas University in Milan, and delighted to be here with you today.
All right, thank you, Maurizio. How about Dr. Janet Diaz?
Hi, my name is Dr. Janet Diaz. I'm a pulmonary critical care physician, currently working at WHO as the lead for the clinical management team here in the emergency program and such the clinical management response for COVID-19. So nice to be here and thank you.
All right, thank you. Dr. Flavia Ribeiro Machado?
Hi, hello everyone. Thanks for the invitation. I'm an intensivist, professor of clinical care at the Federal University of São Paulo in Brazil, and it's a pleasure to be here discussing this with you today.
Thank you, Flavia. And Dr. Zarir Udwadia.
Hi, greetings from Mumbai, India, where I'm a chest physician at the Hinduja Hospital, a large private hospital in Mumbai.
All right, thank you very much. And before we begin with our first presentation, we have some housekeeping items to review. So today's session will be recorded, and the video links for the session will be posted on our website. You'll find a link to the website in the chat box in just a moment. Please note that it can take up to 48 hours for the recording and the slides to be available. Please also note that because of the large number of participants today, that the network will be in listen-only mode for this session. And if you would like to submit a question, look to the bottom of your screen, and not the chat box, but the Q&A box is where you want to submit questions today for the speakers. We have received over 200 questions through registration, and we anticipate that we'll get many more questions as we go today. So we apologize in advance that we likely won't get to all of your questions, but we'll get to as many as we can today. Please refrain from answering questions in the Q&A box. And then also keep an eye on the chat box at the bottom, because you will see several resource links posted there by our ECHO digital librarian. And then at the end of today's session, we will be posting a link to a survey that you can complete. That will also be in the chat box. And if you complete that, you'll be able to obtain your CME and CEU credit. And so thank you very much. We don't need to share the housekeeping slide anymore. We're gonna go ahead and start today's session with an update on COVID-19 from Dr. Swaminathan of the World Health Organization. Dr. Swaminathan is an Indian pediatrician and clinical scientist known for her research on tuberculosis. And Dr. Swaminathan has been chief scientist of the World Health Organization since March 2019. Prior to that, for the preceding couple of years, she was the Deputy Director General of Programs at the World Health Organization. And Dr. Swaminathan will be joined in this overview by Dr. Janet Diaz, who will also be providing an overview. And Dr. Diaz's vision is to support clinicians working in limited resource settings around the globe for better care for critically ill patients in a compassionate, high quality, safe, and just manner. Her priority is to build local clinical capacity by opening access to the highest quality information and medical knowledge, and developing practical skills and clinical management approaches that are fundamental to the care of critically ill patients. So thank you, Dr. Swaminathan and Dr. Diaz for providing this overview.
Thank you, Matt. And I hope you can see my screen. Okay. So I'm going to run through a little bit of the EPI update to see where we stand today. And then we're going to move into a little bit on the research and then on the clinical guidelines. And Janet is going to do that part of the presentation. So just as of the 1st of November, we can see that we have almost, 3.5 million cases a week now. So the epidemic continues to accelerate. You know, we have over 500,000 cases being added every day, and 45,000 new deaths again. So deaths ranging between 5,000 to 6,000 a day, but number of cases exponentially increasing, and cumulative numbers, you can see almost 46 million cases and 1.2 million deaths. The different colors you see on the graph actually reflect the different WHO regions. And you can see that while till a few weeks ago, it was the Americas region, North and South America, that had the bulk of infections, over the last 2 weeks or so, you can see in green, it's the region of Europe that's really contributing to over half of the global cases. Luckily, the Southeast Asia region is now into a slight decline, mainly because of India and Indonesia. And the Eastern Mediterranean region, there are a few countries in that region that continue to show an increase in transmission. Overall, we can say globally that we are not slowing down at all. And you can see also on the right-hand side of the screen, the countries with the highest number of cumulative cases. Now, of course, when you look at cases reported over the last week per million population, then you can see the differences between countries. The darker the region, the higher the number of cases per million. So again, Europe, the United States, Argentina, Colombia in the Americas region, and then there are some other countries. The Russian Federation also recently started showing an increase in the number of cases. Similarly, the UAE and Iran and Iraq. The same thing for deaths. So these are mean deaths over the last 7 days reported again per million. And again, it's you can see that Europe, there are many, many dark green areas in Europe and in Latin America. And overall, the death rate per million population is lower, much lower in Southeast Asia and in large parts of Africa. And of course, this is good. There are many reasons for this, but it's also good to keep an eye on the deaths. Of course, we know that there are limitations both in the counting of cases and in the counting of deaths. So whenever we talk about case fatality rates or infection fatality rates, we must recognize the fact that we are undercounting both cases because we are only counting those that are being diagnosed, and also possibly undercounting deaths in large parts of the world. Many of the high-income countries have systems that report on the overall number of deaths. So we know the extent of excess mortality in many of these high-income countries. But in large parts of the world, we do not know what the excess mortality is over the last 10 months, how much of it is due to COVID and how much of it is due to other diseases. So WHO is advocating for rapid mortality surveillance in countries which do not have inbuilt systems, so that we better try to understand the impact, the overall impact that this pandemic has had. We also know that the diagnostics availability has improved a lot, has really expanded over the last several months. And so we can't compare number of cases that were being detected in March or April, for example, compared to what is being detected now in Europe, because it was estimated that currently maybe half the cases are being detected, whereas earlier in the year, it was probably less than 10%. It was only the severely ill patients, symptomatic, who got into hospital. Just moving very quickly over into the primary symptoms, we know that symptoms can appear anytime from 2 to 14 days after exposure to the virus. And that is why the 14-day upper limit for quarantining of contacts. The loss of smell or taste is a unique feature, whereas actually a runny nose is not, so it shouldn't really be there. But we know you can have cough, sore throat, shortness of breath, fatigue, fever, chills, nausea, vomiting, and diarrhea, and headache are the other symptoms. We also know the majority of people have mild symptoms, mild to moderate, and 10 to 15% progress to severe disease, 5% or so become critically ill and require intensive care. Most people recover in about 2 to 6 weeks, and we know that the post-viral fatigue can happen with other viral infections as well. But in this case, it does seem to be quite a multi-systemic sort of infection. We know that people who have more severe symptoms take longer to recover, and that many of them complain of symptoms for many months. Now, there have been surveys done in a couple of countries, in the US, in the UK, and others. And you can see that a phone study done in the US looking at self-reported symptoms 14 to 21 days later among outpatients, quite a large number of patients, 40 to 50% still reported some symptoms or the other. And I think only the long-term cohort studies will explain to us or tell us what these symptoms are, what exactly the pathophysiology is in these organs, like the brain, for example, the heart, the cardiovascular system, as well as the respiratory system, where I think some of our panelists are going to talk about that. And again, other studies from SARS-1 even showed that 40% of people had chronic fatigue symptoms years after being diagnosed. So we know that many organ systems can be impacted: the heart, the lungs, the brain. We know people get thromboembolic events. Mental health, it's really got exacerbated, both the direct effects of the virus as well as a lot of indirect effects. The stress and anxiety and depression due to people's loss of jobs, loss of livelihoods, just the uncertainty. Musculoskeletal and other systems. Now, very quickly, I want to say a few words about research, because I think that's been quite a unique feature of this pandemic, the speed at which research got started across the world in many countries, a number of clinical trials that are going on. As far as WHO is concerned, we acted on this research and development blueprint that was developed after the Ebola West African experience. And really the idea was to be ready to undertake research whenever there are outbreaks due to some of these high threat pathogens. And so as soon as an outbreak was declared, so even before the public health emergency of international concern was declared, this mechanism had already gone into action, had started convening experts from around the world. It resulted in the Global Research Roadmap, which came out on March the 1st. and has also resulted in a number of clinical trials, including large trials like the recovery trial based in the UK and the Solidarity trial, which is a multi-country trial that was coordinated by WHO. And we know now that you need these large trials to definitively answer questions or hypotheses that you may have at the beginning of the pandemic. So the Solidarity trial of drugs was really looking at big outcomes, public health relevant outcomes, like all-cause mortality. That was the primary outcome, subdivided, of course, by severity of disease at the time of randomization. And the secondary objectives were to look at the duration of hospitalization and the need or the progression to ventilation. So this is now out on medRxiv, the results, and hopefully will be published very soon. It looked at 4 repurposed drugs, remdesivir intravenously for 10 days, hydroxychloroquine given at a fairly high dose for 10 days, lopinavir, ritonavir given orally, also for 10 days with interferon beta 1A given mainly subcutaneously, except in a few cases where it was given intravenously. And there was an arm of interferon with lopinavir, ritonavir, and an arm without that. And that was given for 6 days. So we had, by the end of the interim report, 30 countries enrolling, over 400 hospitals. And currently it's enrolled more than 13,000 patients, enrolling at about 500 patients a week. So it turns out to be a good idea to have a clinical trial that's enrolling in different parts of the world, because even as the epidemic waxes and wanes, you still have some countries and regions which have ongoing transmission. So you continue to enroll into the trial. Now, very briefly, just looking at the results, you can see these Kaplan-Meier graphs with blue lines, which are the control arm, which in this case was standard of care arm, which means that in any particular hospital, patients who were randomized to standard of care got everything they would normally have gotten in terms of treatment and supportive care, except the intervention of choice. And you can see that none of the 4 repurposed drugs that we tested, actually there was no significant difference on mortality, in hospital mortality, cut off at 28 days compared to the standard of care. And this is just a blow up of the remdesivir results because there's a lot of interest. There's one other well done randomized clinical trial, a double-blind placebo-controlled trial done by the NIH, the ACTT1 trial, where the primary endpoint was not mortality, it was the resolution of symptoms. And there they used a scale of 0 to 7, and anyone who moved down the scale was considered to be improving. They showed that you could reduce the time to recovery from 15 days to 11 days, or 10 days rather, in the published report. And they also did not find a significant reduction in mortality. There seems to have been a trend. So in terms of the endpoint of mortality, both the ACTT, NIH trial and the Solidarity trial actually have the same conclusion. But we also looked at the subgroup of people who were not ventilated at the time. So majority of patients actually were not on ventilation. We had only 8% of the 11,000 patients who were on ventilation to begin with. And those patients, clearly remdesivir didn't work. It was too late possibly. But even in people who were earlier in the course of illness, those who were not on oxygen and those who were receiving oxygen, there didn't seem to be really much, at least there wasn't a statistically significant difference. You can see the confidence interval ranges from 0.72 to 1.04. So that's the range in which remdesivir may have an effect on mortality in that group of patients. And again, there was, when we subdivided by age, by respiratory support at entry, didn't make a difference. So looking at there are 4 trials of remdesivir reported till date. The Solidarity is the largest trial, 604 deaths out of 5,000 randomized. The ACTT trial I mentioned was 136 deaths in about 1,000 randomized. 2 smaller trials, including one done by Gilead and one in China, much smaller, only 41 deaths. And as I said, the ACTT1 reported remdesivir reduced the time to recovery. So potentially, one could think about the use of remdesivir earlier in the course of illness, but again, I think cost and benefit needs to be taken into account. So we really need to define that. But just looking at the meta-analysis of mortality, in all of these trials and subdividing the patients. You can see on the Solidarity was divided into no oxygen patients getting either low or high flow oxygen and ventilation. And you can see from those black boxes, squares, that there was no significant reduction of mortality in any of these three groups. Looking at the NIH study, there was one subgroup on the low flow oxygen where they did find that there was a reduction in mortality, but there was an imbalance in the randomization of patients in this arm, and this was not a pre-specified analysis. But it's still, this subgroup is the one that that the NIH scientists consider could benefit from, but it's based on these very small numbers. You can see just 9 deaths in the remdesivir arm and 25 in the control arm. And then there are the other studies from Wuhan and the SIMPLE trial from Gilead, which was not a placebo-controlled trial. It was more an observational study. So that's the overall meta-analyses of results on remdesivir. And combining the data from all the four, for the death, the rate ratio was 0.9 with the confidence intervals again ranging from 0.79 to 1.05. So this suggests that this result could be by chance, or it's possible that there's a small benefit in lower risk patients. So what we concluded is that, of course, we need more evidence on remdesivir, but really what we need are better drugs, and we should be doing more trials looking at other options. As far as Solidarity is concerned, we'll stop randomization with interferon, may continue with remdesivir till we still have some supplies left. But basically what it is it's a platform, as I mentioned, for testing in an adaptive way, newer therapeutics, which are coming out now out of the pipeline. So I'll just mention, I think I'm going to hand over to Janet here to take over from here and talk to us about the guidelines that the work that she's been leading. And just to say that the guideline work actually considers the global evidence base on any drug. And we're trying to work in a way that's more efficient, that is very proactive, that brings together all the clinical trialists from around the world that are working on a particular drug. But the Solidarity trial, even though it was coordinated by WHO, will be treated in exactly the same way as other trials that are done and that are graded using the grade system and so on. So turn it over to Janet now.
Thank you, Soumya, and thank you for this opportunity. As you can see here, this is the Therapeutics Living Guideline for COVID-19. And as you just heard, what our plan here is that once evidence is generated, then as everyone knows, the evidence needs to be synthesized. And the best way to do that is, through a meta-analysis type of process. And so what we've put into place here is that as soon as trials start to read out or they start to publish their results, that we have set up a team with many collaborators supporting our work that will take that evidence, synthesize it in a meta-analysis, and in these cases also doing a network meta-analysis, and then show that evidence synthesis to an independent expert panel. So this is quite important. So what we're trying to do is separate those that generate the evidence, the researchers, from those that actually do the evidence synthesis, to those that actually help us formulate our recommendations, which is an independent expert panel, which is from all regions of the world. So we're very careful kind of in the sense of who we invite to become our expert panel members. That is also reflective of different specialties, and in this case, obviously infectious disease or virologists, as well as intensivist and primary care doctor. And within representing the different specialties and different expertise out there. And then we develop draft recommendations, and that recommendation then gets reviewed again by a different external panel. And then by our internal publication review committee. So there's many steps to this to ensure, good quality science, trust, transparency in the process, so that people believe, with what we're doing and it's publicly available, and that it's trustworthy. So And doing this is the process we have set up. And so the corticosteroid guideline for COVID-19 was the first living guideline that we produced, and that was published early in September. And from that experience, and that one took us about 7 weeks from availability of the evidence to publication of the guideline. And in the big picture, that was quite fast for a WHO guideline, where we have traditionally spent up to a year or longer writing guidelines. But this, in the pandemic, we've had to find systems of how can we maintain the good, trustworthy, good quality guideline and do it faster without losing quality. And I think, it's a challenge. It's not been, and we are learning, but we are getting faster. So currently, the target publication is within 3 to 4 weeks from availability of the data. And right now, based on the preprint release of Solidarity, we were able to activate the guideline panel to review evidence from remdesivir, lopinavir, ritonavir, and hydroxychloroquine. And those recommendations are all in process right now. Next slide. And so I just wanted, this is just a really high level slide to say, at the same time, we know there's many pipeline therapeutics. And as you can see, they can be repurposed or new drugs. And I just want to highlight, again, some of the interesting things that are being studied out there, and looking at the vitamins, vitamin C, vitamin D, and this is not all inclusive. So this is just to highlight a few. Anticoagulation studies looking at intermediate dose and therapeutic dose, in addition to comparisons with prophylactic dose. The immunomodulators with interferons, as Samia has already described, as well as the IL-6 receptor antagonists, convalescent plasma, and IL-1 receptor antagonists. Many repurposed antivirals. I'm not going to go through the ones that we already discussed, but as you know, there are many in clinical trials ongoing. And then novel therapeutics in early phase trials on small antiviral molecules, as well as monoclonal antibodies that are listed here on this slide from Regeneron, GSK, and Eli Lilly. Next slide. But I don't want to forget actually one of the most important things. So as we go into clinical management, and many people, the hot topic is therapeutics, and what's saving lives. And I seem to have lost just one slide on this. And right now, as Samia has already told you about the results of Solidarity, which is an incredible study, that along with the other large trials that have been testing multiple interventions, that the only drug that has now been proven to reduce mortality in COVID-19 is corticosteroids. So corticosteroids, based on our meta-analysis, did show that a reduction in mortality, and the recommendation that WHO has since published is to use corticosteroids in patients with severe and critical disease. And that's a strong recommendation. And then the second recommendation WHO made, that in patients with non-severe disease, those, for example, with mild disease, that corticosteroids should not be used, as there seems to be no benefit in those patients and a potential risk of harm. But aside from that, what do we have is good clinical care. And I know my colleagues, Flavia and Maurizio, will discuss this in more detail than I will, but this is the COVID clinical care pathway. This is the importance of recognizing early if the patients have COVID by the screening mechanisms in place that you have. The second thing is triaging patients and doing a proper clinical assessment to find those with any signs of severe disease or progressive disease, or patients are at high risk. And now we know that patients, not only do they develop severe pneumonia, severe pneumonia, ARDS, but they can have multi-organ dysfunction. They can have neurological complications, cardiac complications, renal complications. So all this is important in your clinical assessment, and then ensuring that high quality, good, safe, supportive care is started. And that will depend on whatever clinical syndrome they have, be it sepsis, be it severe pneumonia, but things such as oxygen therapy, a first-line treatment for patients with severe pneumonia, those that require oxygen. Potentially the use of non-invasive ventilation or high-flow oxygen for advanced respiratory support in those patients that have worsening respiratory distress. And in some patients, invasive mechanical ventilation. So I think putting into place a COVID care pathway that enables patients and clinicians to monitor their patients closely, to treat the complications they may have, is essential in order to provide safe care. And my final slide here is just a pitch to the COVID clinical data platform. You can find this on our website. this is really important to get the clinical characterization of disease. And as you saw before, we have different rates of mortality around different parts of the world, and we need to understand why. What is driving that difference in mortality? What is it about? Is it the care? Is it the patients? Is it the risk factors? Is it the different parts of the world? And with this clinical data platform, we are collecting anonymized patient data from hospitalized patients. We have over 70,000 patients now in this platform from 32 countries, and really making a big effort to reach out to those, to share anonymized patient data so we can start to develop both country understandings of the clinical characterization to guide clinical response, as well as a global understanding or a regional understanding of the variations in clinical characterization. So with that, thank you. I think I went over time, but I appreciate the opportunity. Bye-bye.
All right, excellent overview. Thank you, Dr. Swaminathan and Diaz. So we're gonna take about 5 minutes to do some question and answer before transitioning to our other panelists. And I'll go ahead and share one of our live questions. So this is a question from Terry Harrison. Can you comment on how testing impacts the number of reported cases?
So yes, obviously testing plays a very big role in the number of reported cases. And that's why I mentioned that when you see graphs that show the first wave, so-called first wave, and the so-called second wave, March, April of this year, and then now, you can't compare. It's not that that many more people have got infected. It's just that we were not being able to detect at that time people who were infected. And in many countries, only those people who were sick, who landed up in hospitals, were getting tested. So I think we were only picking up the tip of the iceberg. Now, in many countries, because of the diagnostic capacities having increased, there are many more diagnostic tests available, kits, including rapid diagnostic tests, antigen tests that countries are using. We are able to not diagnose every person who gets infected, but certainly a much larger proportion. And that's why we also see quite a large number of them are asymptomatic or with very mild symptoms. Over,
Right.
Matt.
Thank you. Here's a question from Ellen Evans. So earlier studies showed that the effect was for early exposure, early onset, rather than at the time of hospitalization. Is it possible that the World Health Organization study is selecting for failure of antivirals by selecting later onset of treatment? Could you comment on that?
Yeah, I think logically speaking, we know that antivirals are likely to act earlier in the course of infection. All the studies of remdesivir done so far have been in hospitalized patients, all the clinical trials that I mentioned. I'm not aware of studies, and also because it has to be given intravenously, it is a limitation. I think the company Gilead is working on an inhaled version of remdesivir, and it may be possible to test that much earlier in the course of the disease. I think the same thing applies to other antivirals, but one thing I would say about the Solidarity trial, firstly, it's a very large number. And as I mentioned, 5,000 patients were randomized to the remdesivir versus standard of care arm. Only 8% of them were on mechanical ventilation. So about 40% were in hospital, but without oxygen, and another 40% or so were receiving either low flow or high flow oxygen. So there was a spectrum of clinical stage represented. But if it's even earlier than that, if it's given on the first day or second day after diagnosis, even before any symptoms develop, then what effect will it have? We don't know. And this is the same question for the monoclonal antibodies. Again, they have to be given intravenously. We know they'll work better if they're given earlier in the course. But then who do you give it to? You can't, these drugs are not, first of all, available in the millions of doses. And secondly, they are expensive. And so I think we need more research to define perhaps that high-risk group that might benefit from these drugs if given earlier on. But that's going to need more research, more clinical trials. So we can only conclude from what we have to date.
Okay,
Matt?
thank you, Soumya. Sanjeev, over to you.
Yes, Soumya, I think just taking this one step further, as you know, recently, if the Food and Drug Administration in the United States actually approved remdesivir for for treatment of COVID-19. So many of our clinicians are interested in what would you actually do. Of course, we understand the Solidarity trial and the controversy there, but a clinician in the community right now has remdesivir available in the United States. They have it available in Europe. I'd like to just have you and your panelists just comment on that one issue. A person comes to you, he's not really on a lot of oxygen, having some symptoms, maybe a little cough and some fever. And the primary care doctor has seen this person and now wants to figure out, should they use remdesivir on this person? It's early, they made the diagnosis, what should be done?
It's a very valid question, and I'm going to ask Janet to come in as well. So I want to distinguish between the results of the Solidarity trial that I presented and us making any recommendations. So, when an RCT reports out, it can only report out on the results that you find in that group and what you did in that particular trial. So it is the guideline development group that will look at the global evidence on remdesivir as well as on the other drugs. And I know that individual countries are making treatment guidelines also, and hopefully they would use the same evidence-based approach. But the WHO guidelines, Janet mentioned in her talk, that they are working, the guideline development group is already working on the meta-analyses of all the available evidence on lopinavir, ritonavir, hydroxychloroquine, and remdesivir. And I think the timeline is quite soon. So within the next couple of weeks, we should have, and that's the treatment guideline. So I don't want to preempt that by saying this is what clinicians should do, because I think we have to wait for the treatment guideline, which will be based on all the available evidence and using the correct methodology of assessing the quality of the evidence, which is a great methodology.
Thank you. And Zarir, Flavia, Maurizio, and could you just say, would you use remdesivir or not? Just so that we can move on. Just answer yes or no.
Well, because we have nothing else better, I would still continue to use it, hoping that it will reduce hospital stay.
So Zarir, yes. Maurizio?
I'm there because I'm also part of the WHO Clinical Guideline Committee. So I can tell you at the moment in Italy, it's very difficult to get the drug anyway. And my feeling is actually that the resources should be directed to other things at the moment, which I will mention also during my talk. So,
Flavia?
Remdesivir is it's not available in Brazil, so for us it's easy. We don't use it. But if it was available, I think that I would say that this would be in the same way of Mauricio. I would not support it, not without good evidence.
Thank you. Okay, back to you, Matt.
All right, thank you, Sanjeev. And I think we'll go ahead and transition to our expert panelist presentations now. Dr. Swaminathan, I'll go ahead and review the bios and then pass over to you. So starting with Dr. Zarir Udwadia, who is a consultant physician at Hinduja, Breach, Candy, and Parsi General Hospitals. He combines an extremely busy clinical workload with more than 10,000 patients annually in his clinics, with quality research as evident from his almost 200 medical publications. He is best known for his work on drug-resistant TB and was invited to join the USAID India NTB Alliance and the Global TB Network to pursue global TB elimination. He's been advisor to the World Health Organization and was invited to Geneva on several occasions to help formulate the current TB and multi-drug resistant TB guidelines. In 2017, Open Magazine nominated him as one of their 25 top minds for his impact on public health. He's given 2 TED Talks, one on drug-resistant TB and the other on COVID-19. And then Dr. Maurizio Ciccone graduated from both the University of Udine's School of Medicine and Surgery and the School of Anesthesia and Intensive Care in Italy. And during his training, he won a grant for young investigators from the Italian Society of Anesthesia, Analgesia, and Intensive Care that allowed him to become a visiting fellow at the General Intensive Care of St. George's Hospital, London, UK, where he went to study perioperative hemodynamic optimization of high-risk surgical patients. While he was there, he undertook a doctoral degree at the University of London. He spent 2 years performing research on the evaluation of novel techniques for measuring cardiac output in critically ill patients. His main fields of research are hemodynamic monitoring, hemodynamic optimization, and physiology of the critically ill patient. He serves as chair of ESICM's cardiovascular dynamics section. And then finally, Dr. Flavia Ribeiro Machado is currently professor and chief of the Division of Critical Care in the Department of Anesthesiology, Intensive Care, and Pain at Federal University of Sao Paulo. Her area of expertise is critical care medicine with emphasis on sepsis. She is currently CEO of Latin American Sepsis Institute, or LASI. She is also a member of the executive committee and the coordinator of the scientific committee of the Brazilian Research and Intensive Care Network, and member of the Latin America Research Network, an executive board member of Global Sepsis Alliance and the Council of International Sepsis Forum. She is a board certified intensivist by the Brazilian Association of Intensive Care Medicine and has been since 1997. She was also the editor-in-chief of the Brazilian Journal of Intensive Care, the official journal of Brazilian Association of Intensive Care Medicine, and the Portuguese Society of Critical Care, being now the associate editor. So thank you to all of our panelists, and we'll begin with Wadia.
Thank you. I hope you can see my screen.
Yes.
And hear me. Great. Thank you, Matt. So, these are the learning objectives that Soumya's entrusted me to. I'm going to speak about COVID prescription patterns in India and stress the importance of following guidelines. I'm going to talk about the link between COVID and tuberculosis to airborne pandemics or syndemics. And I will touch on post-COVID lung fibrosis, which is a dreaded sequelae that chest physicians around the globe are seeing more frequently. A quote from Shakespeare to start things off: "Thus bad begins and worse remains behind," he said in Hamlet, and he could have been referring to the pandemic. Soumya's touched upon this, but I will say that just 2 days ago, India became only the second country to cross 8 million cases. So we are struggling like the rest of the world. Now, guidelines exist in India, but are seldom followed. That applies not just to COVID, but to TB and infections of all kinds. Uncontrolled, unregulated polypharmacy is sadly the rule. Inappropriate and multiple antibiotics thrive. Some old favorites like HCQS have still not been put away. And there are some inexplicable choices like ivermectin. The kind of prescription I see all the time, you'll notice it's a long prescription with 10 drugs on it. And I've highlighted some of them, which are clearly inappropriate, starting with the multiple antibiotics that most patients at home seem to get. And you know that most COVID patients are home treated. So it's rare to find a patient's prescription without azithromycin and doxycycline for some reason featuring prominently. Moving to hospitalized patients, of course, in the third week of illness, they have high rates of secondary hospital-acquired infections, but the use of antibiotics like meropenem empirically is bound to promote further resistance. And clear guidelines from the IDSA that we should not be using azithromycin at home. And the WHO has warned about a forthcoming pandemic of drug resistance, the way that antibiotics have been widely used and abused at this time. We were early adapters of chloroquine like the rest of the world, but at that time there was no option. It remains a strange and a firm favorite despite evidence to the contrary. It's impossible for rheumatology patients to buy this drug still at most pharmacies because it's short-stocked. And many Indian doctors continue to poison themselves using it as prophylaxis for themselves. You've heard of Solidarity, but Recovery also closed its HCQS limb a long time ago. If you are admitted to hospital, don't take HCQS as the message, it doesn't work. This was appropriately called the HYPE study, and prophylactic doses of HCQS are also not free of side effects. A third of Indian doctors had to stop because of major gastrointestinal toxicity. Then there's the strange case of ivermectin, popular in South America and extremely popular in India, without a single RCT, even hinting that it has a role to play. So I'd like to come down strongly against the continued use of such drugs. And what can I say about cures like this promoted by Godmen? Really, we should legislate to prevent them preying on the gullible population. In hospital, we've seen tocilizumab used in multiple doses, doing nothing but adding to sepsis, and remdesivir going on for extended periods of time, far more than the recommended 5 or even 10 days, just because the patient is still stuck on a ventilator. And of course, sadly, counterfeit, fake, and black market drugs continue to thrive in my country as well. We wrote an op-ed piece in the one of the popular papers in the country, stressing what we should and what we should not be using. And I'll close out this segment of my talk by telling you our 7 messages, which I think carry some weight. We said there are few proven treatments for COVID. We stressed that the majority of patients would get well on their own with or without any treatment. We said that many drugs in current use are likely to do more harm than good, that most COVID studies are anecdotal, observational, and one must recognize these as being inferior to RCTs. We urge that our physicians avoid the compulsion to prescribe multiple drugs. Call it polypharmacy, though the general practitioner would perhaps say it's polypragmatism, if I may coin a new word. Guidelines exist, and I just wish they were followed. We need to modify our practice as new data emerges, because look, this is a new disease for all of us, and we are all learning. India has had, despite all this, less deaths and faster recoveries than most other countries, but that could just be a reflection of the median age. The median age in India is 27 years. It's a young country. More than 65% Indians are less than 35 years of age. That's a good demographic, and perhaps that is why we have less deaths and quick recoveries. I need to spend a couple of minutes talking about COVID-TB interactions. And this was a review article we wrote talking about these dark forces colliding. And I've had to redo this slide so often because 10 million for TB, 10 million cases for TB globally, I thought was huge. It could not be eclipsed by any disease. But then we have COVID, 50 million in 10 months and expanding rapidly. And there is bound to be this merged common ground between these two syndemics. And we have been tracking our TB and COVID patients very, very carefully. We wrote in the review that the impact of a novel virus on an ancient bacteria is likely to be devastating. And just as another virus, HIV, did to TB control 3 decades ago, the effect of SARS-CoV-2 is bound to set back global TB control by several years. Our TB patients are suffering. Our programs are suffering as well. And this was a just released global TB report from the WHO, which said the COVID-19 pandemic is likely to leave a profound and long-lasting impact on TB diagnosis and control, with an additional 6 million cases of TB and an additional 1.5 million TB deaths over the next 5 years. Notifications in India have fallen precipitously. Monthly notifications compared to the same time last year are 30% lower. What does that mean? That means 1/3 of all our patients are just flying under the radar. They're not being picked up. And 30% lower reductions equals or equates to 3 million more people in India dying from TB over the next couple of years. So that's frightening. I want to touch on briefly the sequelae that we are seeing in some of our most severe patients, the more sick patients, the longer ventilated patients of post-COVID fibrosis. CT scans like this we have seen all the time. They are acute, typical stage of COVID with the peripheral ground glassing that is so typical. Most of these patients will recover and in 3 months be left with a normal scan. Most of them, the majority. But we do see, and this is the patient that we reported in the very early days of the pandemic, patients ending up with a fibrotic pattern indistinguishable from IPF. You can see honeycombing, you can see traction bronchiectasis. For all the world, this is fibrotic lung disease. And lung fibrosis was rare with previous viral outbreaks like SARS, like MERS and influenza. But COVID has dwarfed these outbreaks in terms of sheer scale, if nothing else. And post-COVID, pulmonologists across the world are observing that fibrosis occurs more frequently, it occurs more rapidly, and on occasion, these patients seem to progress. So it's an unimaginable scale we're talking of, 46 million patients yesterday. And if even 10% of these have severe ARDS, we're talking of currently 4.6 million people with pneumonia and ARDS in ICUs across the globe. And let's say that 90% of them will recover without any scars on their X-rays or CT scans over the next 6 months. That will still leave you with 10%, which equals 500,000 patients and counting with residual lung fibrosis. like this one, for example, who in 27 days moved from extensive ARDS to end-stage fibrotic lung disease needing a transplant. The treatment of post-COVID lung fibrosis, we don't know whether the antifibrotics have a role, and of course the standard therapies which we all use. So what is really needed, considering the scale and the impact of post-COVID ILD, is urgent trials with existing and novel antifibrotics, biomarkers to identify which patient is likely at the stage of ARDS to progress to fibrosis, and very careful data collection longitudinally. I'll end with this quote from Elizabeth Pathak in the BMJ: "The desperation engendered by COVID-19 demands that we strongly resist the urge to succumb to pandemic research exceptionalism. Low quality research not only wastes scarce resources, but is inherently unethical." Thank you. I will stop sharing my screen here. And I have been a minute over. I'm sorry, Sanjeev.
Thank you. Thank you very much, Zarir. Maybe we now go on to our next panelist, Dr. Maurizio Ciccone. Over to you, Maurizio.
Hello, everyone. Can you just tell me that you can see my screen?
Yes, we can. Thanks.
Okay, so thank you for this opportunity. I'm actually, for the last 3 years, I'm now based in Italy, in Milan, where I head the Department of Anesthesia and Intensive Care Medicine, and I'm the President-elect of the European Society of Intensive Care Medicine. I don't have any financial disclosures for this talk, and these are my academic conflicts of interest. So, first of all, I really would like to make an important point, which is a little bit in line also with the one of the previous speakers, in the sense that this crisis, this pandemic, has really brought intensive care under the spotlight, and there have been many treatments proposed and tried for this. But actually, I really think the biggest problem of this pandemic is the number of patients that come to the hospital at once. It's not that we were not used to see pneumonias before, or viral pneumonias. Of course, there are some specific features of COVID-19, but what has really put a lot of strain on our systems was the fact that if the transmission of the virus in the community is left without control, you can have an exponential rise on cases and proportional of cases that would come to intensive care. And this can put any healthcare system on their knees. So even if we are an important part of this response, I think we're the last line of defense. And there has been a lot of talk around triage and whether there should be criteria or not to admit to the intensive care. I personally don't like to put strict criteria on paper on this. I would say that probably one of the biggest skills that an intensive care doctor has to have, and I worked in different countries, is to understand how the physiological reserve of patients is, not just based on age, not just based on classifications of comorbidities, but really try to understand in a way that together with patient choice, family choice, the culture of the place where you work, which one is the patient that will benefit the most for intensive care. This is what we did with my team, trying really to increase into surge ICU capacity and not deciding to put doors at the gate of the intensive care, just depending on the number of beds available. Another important thing to remember is that despite the fact that this is a new disease, we have a lot of indirect evidence from the past in intensive care. What we do in intensive care is organ support, and it's basically supportive therapy at a very high level. In practice, we are buying time for the body, for the patients to heal. There has been a lot of misunderstanding also on whether COVID-19 ARDS was really an ARDS or not. We've demonstrated that it is within the spectrum of ARDS. Of course, there are some specific features of this virus so that the average compliance, for instance, of patients coming to our intensive care is slightly higher, but it does not mean that we should treat every patient with the same recipe. However, we should try and find the evidence from the past and using supportive therapy, using very precious tool. I'm sure that Flavia will speak more about this later, like protective lung strategies and proning, for instance. Really, lots of ways in which we can try to prevent patients to come to the intensive care, maybe by timely supportive therapy, maybe by using steroids in patients in oxygen before they come to the point of reaching the stage of intensive care. But I have to say, never in my life I've seen so many drugs used and tried without a lot of evidence. I'm very grateful to studies like REMAP-CAP, Recovery Solidarity for bringing some strong evidence. And to me, the evidence, first of all, is primum non nocere, first do no harm. What I really think we should do in our intensive care is trying to do the basic right in every patient: timely intervention, protective lung strategies, supportive therapy, mobilization, sedation holds, and staffing ratios are really important, trying to have an adequate number of competent people. I come to this because I really think there has been a lot of misunderstanding, and I represent intensive care doctors across the globe now. I really think too often we talk about ventilators as if they were the limiting factor for intensive care. The biggest lack of resources that we had in intensive care were people. And I like to say always that ICU beds are ICU people, starting from patients, families, but really trying to have an adequate number of competent people at the bedside. It's impossible to train specialists. Specialists should really be the one making the difficult decisions. For instance, understanding which patient will benefit from intensive care and direct the care of these patients. But what we have to do is to accept that in a moment like a pandemic, we cannot train new people or hire new people. There is just not enough time. The best thing that we can do is to retrain, to refresh people that maybe work in our intensive care unit, or try and train people that can convert their clinical work maybe to help in a surge in our departments and in our intensive care unit. We use a lot of simulation during the first days in my team. It was very important for me to make sure that everyone was proficient, for instance, with donning and doffing. I think we have a strong duty to protect our workers, but also our patients. Donning and doffing, if done properly, can be very important to protect our patients. However, at the same time, it's working in a condition that we're not used usually. And we have to remind ourselves that the protective equipment is protecting us from the virus, but not the patient. So we still have to put maybe extra gloves, gowns, wash our hands, and so on. Otherwise, we run the risk to see cross-infections there. But the most important thing, and I think where we should put our efforts immediately, is training, education. We have a lot of people that come to our teams in intensive care. They do not work regularly in intensive care. And I think we have to find ways for them to feel safe in working in our teams and to get those competencies. They cannot become intensive care specialists, doctors or nurses. It takes years to do that, but they can become a very important part of our team, feel safer to work with us. So I was very happy that the European Commission heard our thoughts and our questions on how to get more prepared in Europe. And now they funded this training, which is called COVID-19 Skill Preparation Course, C19 Space, which is enrolling with the aim of about 10,000 people, 10,000 healthcare workers across Europe, and is starting now with a track for doctors and for nurses. This is just some virtual reality shooting that we shot in my hospital in Milan. We thought maybe we can even bring new technology to immerse people so that they can feel more familiar with technology that maybe we will see for the first time when they're brought into a situation at the bedside. And with this, I'm just going to conclude really to say that the best thing that we can do in intensive care is to try to have enough people that help us to do the basic rights. So staffing ratios are very important. And I really think a lot of effort should be done immediately on education. Of course, we are ready to use drugs when they have evidence, but people really are where we should put our efforts. Thank you.
Thank you. Thank you so much, Maurizio. We'll go on to our next panelist, Dr. Flavia Mercado. Would you like to share your screen? There you go.
Yes, I am already sharing. Hope you're seeing it.
And just put it on slideshow.
Yeah, yes, I'm putting it. Okay, it's okay now?
Yes, it's good. Thank you.
Yeah, so thank you very much for this. I have no conflicts of interest in this talk. And I would like to start discussing on how patients die when they are in the ICU. So my personal experience, and this is just personal experience, we had around now more than 500 COVID patients in our units. And most of them, they did not die from refractory hypoxemia. Sometimes you can think. Most of them die from refractory shock. They are dying from multiple organ failure. We are dying from renal failure, hyperkalemia, arrhythmias. And at least in Brazil, we are losing a lot of patients. This is the data from EpiMed. It's a quality improvement initiative in Brazil. And we have now registered more than almost 60,000 patients, COVID patients in intensive care units in Brazil. And as you can see, the mortality rates for those who are in mechanical ventilation are really very high. It's up to 70%. And if the patients have renal replacement therapy, it can be even higher. So we are talking about very severe EU patients. They are dying from multiple organ failure. And what we as intensivists have to think is what we can do to avoid that. And I believe that what we can do is just do what we have been doing all these years in intensive care units, which is supporting organ dysfunction. We do not have antiviral therapy at this moment. So what we can do is to, as Mauricio said, is to support life while our patients are healing. And for this, certainly it's key to have a good respiratory management. And as Mauricio mentioned, we first were thinking, are our COVID ARDS patients similar to our usual ARDS patients? Or should we, for instance, get them intubated and mechanical ventilated sooner than we usually do? We thought, maybe we cannot do high frequency, high flow oxygen therapy. We cannot do mechanical non-invasive ventilation because of the risk of aerosolization, because of the risk of delayed intubation. But we learned a lot during this pandemic, and I believe that now we are doing this much better because we are not afraid of doing this. Maybe we do not have evidence to support clearly that these techniques can avoid intubation, but they might help some of our patients. As awake phoning. So we had awake phoning before, but certainly now it's much more broadly used than for our usual ARDS patients. There is no evidence for it, just small studies. And of course, it might help improving oxygenation, but we are not sure about the safety of proning our patients away because they might need emergency intervention in a position that it's not so easy. So what I'm trying to say is that we have learned a lot. We are using our usual mechanical ventilation, protective ventilation for these patients. And we learned that as in other respiratory failure, there is a possible role for other techniques. And how about hemodynamics? We thought we cannot give volume to these patients. This will worse respiratory failure. We know that positive fluid balance is associated with a higher risk of death. And then I also think that we found the balance because hypertension, hyperlactatemia, and other sites of hyperperfusion is also part of the COVID multiple organ failure. So we do need to give volume to these patients, but very, very carefully. For this, we would need to assess fluid responsiveness. But the problem is that, as we know, these techniques are not widely available. So again, what we need a team looking at the patient and trying to find a balance in hemodynamic management. And it's more or less the same about giving or not antibiotics. We have some systematic reviews now showing that only 7 to 10% of these patients have co-infection or super-infection by bacteria. But I'm not sure because this is different from the reality we are seeing in our units. We know that healthcare-associated infections are much more common in low and middle-income countries, as it is multi-resistance. So we need to find a balance of giving antibiotics to those patients that need it, because they are more severely ill and they have signs of bacterial infection, but we should not use it too much because of the risk of multi-drug resistance. So what is a reasonable approach? Always collecting cultures, always reassessing, withdrawing antibiotics if there is no sign of bacterial infection, de-escalate with the results of cultures. And for most important, given a short course of antibiotics, only 5 to 7 days, it's more than sufficient for most of the patients. And as Mauricio just mentioned, preventing healthcare-associated infection. We are using gloves, and this gives us a false sensation of safety. And we need to improve and to come back to our usual way to prevent healthcare-associated infections in these patients. And we should not forget the humanized care that was so important for us, and it still is in our needs. So this is the 8 key points of the humanized care. So we just need to adapt them to COVID, like improving our ways to do virtual visits, trying to give presential visits to the patients if it's possible, improving our communication, both among the healthcare team and the families, caring for the well-being of the patients with our sedation and pain protocols, the healing prevention, music, photos, letters, communications from the family, psychological support, not only for the patients and families, but also for the healthcare workers. We need to prevent and manage it and monitor post-ICU syndrome, because as we know, COVID, most of the times, it's a bacterial sepsis, and we already knew, this is a viral sepsis, and we already knew that bacterial sepsis cause a very severe post-ICU syndrome. And we certainly have to improve our end-of-life care practices. This is my last slide. I just want to say that there are a lot of things that we do not know. We are doing the basics in our ICU, and this it's not enough. We need to find new things. We have already discussed here in this web all the things that we are not sure. So we need to keep trying to find new treatments and solutions without forgetting the team and the patients. In our service, we are not counting deaths. We are counting discharge. We commemorate each discharge. We commemorate the 100, we commemorate the 200, and we have a heart for every patient that is out alive of our unit. And sometimes like this, the patient himself can put his heart in our world. Thank you very much.
All right. Thank you, Doctors Mercado, Ciccone, and Udwadia for these excellent presentations. We're getting some great questions, and for the next 20 minutes roughly, we will lead a moderated discussion. So we're seeing several questions about ibuprofen use. Any role for ibuprofen for COVID-19?
I don't think we don't have any clear demonstration that ibuprofen can contribute. I think it's just one more drug that we have to think about and to seek for answers based on proper clinical trials.
Yeah, I would also say that there are a lot of patients that can be managed outside in the community. They don't need hospitalization. So symptomatic therapies clearly are something that we do for many syndromes in the community. Usually, if this is something that allows the patients to feel better and to eat, to mobilize, to get hydrated, I don't see a problem with it, but I would not call it a specific therapy for COVID-19 in this sense.
Okay, thank you. And then multiple questions about whether there have been any updates on best practices in managing pregnant women with COVID-19, or any updates on mother-to-child transmission of the virus.
Anybody can take it.
Yeah. I'm not aware about any news about this. We had very few pregnant women with COVID in our unit. It's certainly totally different from H1N1. And yeah, I don't think we have a special management for them.
I think transmission from mother to fetus is rare, and generally outcomes are pretty good.
Yeah, I would say also that it seems to be rare events, both in pregnant women. Certainly, we are seeing less in proportion to H1N1, when it was considered to be also one of the risk factors for some of the most severe, presentations. Personally, for instance, in my hospital, I didn't get any, but we don't have a maternal service here. But even in the other hospitals of the group that have it, is not so common. And as the colleague was saying, it doesn't seem to be so serious in the percentage it happens.
And may I just wanted to add on one more thing. Our maternal child health and sexual reproductive health group here at WHO is conducting observational cohort studies on pregnant women, but I would agree with the colleagues that there does not seem at this moment to be any new different recommendations for pregnant women than for non-pregnant women, regardless of, in their disease severity. And our current WHO guideline does have some sections on pregnant women. So I think there is still more to understand, but from what we know now, there is no difference in the clinical management. So thank you.
All right, thank you. And Dr. Redwadia, you had a very nice slide showing the lung changes after recovery. There's a question from Karen Lewis Bell. Which type of patients should be followed up for post-COVID-19 lung fibrosis? And for how long should we be monitoring them after discharge?
That's a great question. I think the ones who are at the most severe end of the ARDS spectrum, those who require more prolonged ventilation, those who are hypoxic maybe at the time of discharge or have unexplained hypoxia, you'd certainly rule out a pulmonary embolism and the development of lung fibrosis. And I would say many of our critically ill patients sadly go home with oxygen on concentrators, and they have this long road to climb before they can get off the oxygen, and some never do. At follow-up, many of them eventually improve. That's the general trend, but there are a fraction who are left crippled with end-stage fibrosis, which just doesn't budge.
If I can just add something to that, I completely agree. Again, COVID-19 is bringing some light to some of these things that we saw in the past from other infections. And for instance, a lot of patients with ARDS that require prolonged mechanical ventilation, we refer this very often to post-intensive care syndrome. And, and these changes are actually common, unfortunately, even in patients without COVID-19. So ARDS, it's a significant risk factor to go back to independency, a full quality of life, and being able also to go back to your work and so on. This is unfortunately something that we see also for COVID-19 ARDS.
All right, over to you, Sanjeev.
Yeah, my question has to do with from Sevato Madikiza from Zambia. Is the heat wave the cause of decrease in COVID numbers in Africa? I know we don't have anybody from Africa here, but we have someone from India. Zared, maybe you can talk a little bit about India. As we are seeing that even though the economy is somewhat open, the cases are declining, and it's different from the rest of the world. What do you think is going on there? And also, if you want to make a guess about Africa, about what's going on there, perhaps you could do that, or somebody from...
I think, as I stressed, it's mainly that we have a younger demographic with the average age, median age in India at 28 to 30. So that may be one reason why deaths are certainly less frequent.
I'm talking about the actually incidence of infection rather than death. What is the reason why in India, for example, you're seeing, and in Africa too, at least this question's asking what's going on, whereas in the US and Europe it's going up.
We started seeing cases coming down just over the last week or so. Otherwise, it was clocking at about 60 or 70,000 cases per day. And with trains opening up just a few days ago, I think we might be on our way to another surge.
Okay. And for Africa, go ahead, please. Go ahead.
Just in Africa, I'm not from Africa, of course, and maybe somewhere else can discuss this. But what I think that it might be happening in Africa is just, of course, there is a chance that we are just not testing people, at least in sub-Saharan Africa. And maybe another point is that, unfortunately, the life expectancy in Africa is different and it's lower. So we do have, as our colleague said, a younger population over there. And it does not only change death rates, but I believe that also contributes to a lower transmission. But it's certainly different in Africa.
But if I could add something, I'm not an expert in public health, but certainly something that we've seen in Europe, for instance, the hot months of the year are also months with less mobility because of schools usually being on a break. And while I cannot bring all the causality from one to the other, certainly in Europe we've seen a big increase after the schools were reopening, and also during the summer people tend to spend more times outdoors than indoors. So I would not underestimate the fact that suddenly you are moving a lot of the society, public transport, spending more time indoors. And maybe this could be one of the reasons, not just necessarily related to heat or other weather factors, but certainly something that we're watching closely, and it's a very important question also to see what's going to happen next year in Europe.
Another question is from Casey Haycox from Arkansas, and she wants to know what's the latest evidence to prevent? I think a lot of healthcare providers all over the world are concerned about acquiring COVID-19. What is the latest evidence? I mean, of course, we in ICUs, I mean, you're wearing spacesuits, etc. But the issue is in the outpatient setting, what is best practice? What's the latest evidence to protect healthcare workers and reduce transmission there to them and to other patients? Anyone can take it, please.
Well, our clinics have opened up at the Hinduja Hospital where I practice, and all I use personally is an N95 and gloves when I deal with patients. In fact, I'm most secure in an ICU because I'm completely donned and doffed up. But here, I think in an outpatient setting, I'm okay with an N95 and gloves on.
Other people for outpatients?
I'm not sure you need N95 in places where there is no high risk of aerosolization. I think that sometimes simplicity brings more safety. In our unit, we have almost all the patients that are in mechanical ventilation in the hospital, and we only use N95 when we were inside the cohorts. When we are in the corridors and in the rooms that's outside the cohorts, we use surgical masks. And we had the lowest percentage of seroconversion in the whole hospital. We had 90% of seroconversion. And places like the emergency department, they had 45. So sometimes, and we do not use, we only use simple things, and everybody just did the same. So I believe that this is safe, and we can use only surgical masks. There is no need for any N95.
Anybody else?
For us, my department is intensive care and anesthesia, and during the surge, we had a lot of anesthetists coming to work in the ICU. They normally just do theaters, and I agree, ICUs, there is a lot of data around the world that are very safe. But interesting, the anesthetists that were doing the outpatient clinics for the preoperative assessment, we did use N95, but it was not the only thing that we used. We were very keen on having social distancing, making sure that people on the waiting room are not crowded and so on. So while our policy was to use N95, I suspect is again sticking to the rules of making sure you have social distancing, hand washing, and all these practices inside the room, but also outside on the waiting rooms as well. And that requires a lot of organization in the hospital.
Thank you. Janet, did you want to add anything from the WHO perspective?
Thank you. Yeah, I think the most important thing is to remember IPC, it's not just about PPE. PPE is an important element of IPC, but it's also about administrative controls, environmental controls. So setting up your system so that each area of the hospital, you know exactly if depending on where it is, it's the waiting room, it's the ICU, or is it the ward, that you have protocols and procedures in place. So what are the practices that need to be put into place in a kind of a systems approach versus just thinking wearing, PPE will reduce the transmission. So I would look at it that way. WHO recommends, as you all know, contact droplet precautions for patients when caring for patients with COVID-19, and as well as using airborne precautions if doing an aerosol generating procedure. So over, thank you.
Back to you, Matt.
Okay, thank you, Sanjeev. So this is a nursing home question from Kelly Davis. Of course, with nursing homes being particularly vulnerable during the pandemic, how are they supposed to survive under the huge cost of testing and PPE? And what happens to our elderly community when nursing homes start closing because it's no longer profitable?
Oh, well, that's a tough question. We in Brazil, as we know, we are a middle-income country, and we are facing a lot of problems, not only with this specific question on house care, but everywhere. So I would broaden the question saying how we're going to manage all this. And I think that the only way is, as Janet just mentioned, to have protocols, not exaggerating, sparing our resources the most we can, because we are going to deal with this for a long time, and we need to spare resource and think wisely. So maybe not testing everyone, maybe reducing and using the PPIs when they are really appropriate. So, and it's standardizing all of the process.
I think they're an extremely vulnerable population, and very frequent testing, if resources permit it, is really the way to go.
All right, thank you. The next question is about anticoagulation. This is from Meenakshi Patel. Should we start DVT prophylaxis, for example, Xarelto, for 14 days at diagnosis?
Can I start? So again, in this topic, what we are trying to do, at least in my hospital, is bringing back indirect evidence from the past. So I would say, first of all, I'm not a big fan of full anticoagulation regimes. We know from this virus that actually DVTs and pulmonary embolism can be maybe more frequent than the usual, but I don't think that would be the evidence, for instance, for anticoagulating everyone. Saying that, if you require hospitalization, by definition, your mobility is a bit impacted in this moment in hospitals. So we start thromboprophylaxis. But for instance, I would not recommend it at home to asymptomatics or to paucisymptomatic patients. So I would say hospitalizations, yes, thromboprophylaxis only, unless there is evidence for DVTs.
I would tend to agree with Maurizio. Every hospitalized patient, I think, should be on low molecular weight heparin in a prophylactic dose. Whether you extend that prophylaxis after discharge to 2 or 3 weeks or longer at home, there is no evidence for this. But if someone at discharge is an extremely high D-dimer level, for example, I would be tempted to add on a small dose of maybe Eliquis, apixaban.
I fully agree with my colleagues. We are doing the same prophylaxis for everyone. We are running a randomized control trial on anticoagulation based on D-dimers. This is still ongoing. I think that we need more evidence for anticoagulation and to detect which patients are we're going to benefit from this strategy. But for now, no. We only anticoagulate patients that having any sign of thrombotic events, but prophylaxis for all.
Okay, thank you. And then this is a question from, actually a combined question from 2 anonymous attendees. So what is the average length of time for immunity after having COVID-19 infection? They had heard 3 to 5 months, is that correct? And is anyone able to speak to proven reinfection cases?
I'm not an expert. I leave the floor.
I think the honest answer is we don't know. We don't know how long the antibodies will protect you, whether it's 3 months or 6 months. We don't even know after their levels wane and fall, whether the protection continues. So I'll be honest and say I don't know.
Yeah, I think that nobody knows, and we are not experts on this, but about the personal knowledge about the infection case, yes, we did have two healthcare workers in our hospital that had COVID twice, with around 3 months from each other. So I do believe in reinfection. I think it's possible, and I think that we need to be aware of this because we need to keep going with our protective strategies, even among those who had already had COVID.
All right, thank you. Back to you, Sanjeev.
How about we know that people with type 2 diabetes are at increased risk. This is Martijn Eon from Maine. What about type 1 diabetes and COVID? Any questions? Anyone?
I think uncontrolled diabetes, whether it's type 1 or type 2, is a major risk factor. Type 2 diabetes is compounded because these patients are generally obese, so perhaps even more so.
I would add, I don't want to make COVID something that we knew from the past because we're still learning a lot. And personally, I also think there are so many things I don't know. But I'm not surprised, for instance, by the comorbidities that are associated with worse outcomes and more severe outcomes compared to other pneumonias. Actually, we know that, for instance, age and comorbidities is usually bad prognostic factors for sepsis from other bacteria or viruses when you get pneumonias. And to me, there is a little bit of an overlap also with COVID-19 in this sense.
Thank you. So what might be the consequences of COVID during the flu season? This is two physicians from New York, Juliana Nainvell and Dr. Pong. We are seeing data basically saying that some data is accumulating that the actual incidence of flu is significantly lower because of all the precautions we are taking. On the other hand, people are concerned about this issue of dual attack. And so what's the latest understanding on this interaction between flu and COVID-19?
I think there are already a few published series out of patients who have first COVID and then the flu. And I keep telling my patients, we don't have a COVID vaccine yet, but you certainly have a flu vaccine. And it would be remiss not to be taking that or recommending that for all our patients at the time of discharge or soon after.
Yeah, fully agree. The key point here is the prevention, and we are preventing it with vaccination and with all the isolation precautions that we are taking. We haven't seen any H1N1 patient or any influenza patient in our units during the last, I believe, since March. So.
And I would also add that, you know, the problem with this pandemic is that it's competing for healthcare resources. So if we have some disease that we can prevent, I think it's a good thing for the whole healthcare system, not just for COVID-19. So I would agree. I would encourage vaccinations personally for older people, also against some other things, like, for instance, pneumococcal vaccinations for older people. That's what I'm advising older people in the region here.
Back to you, Matt.
All right, thank you, Sanjeev. So we'll go ahead and conclude today's session, and we'd like to thank our moderator, Dr. Swaminathan, and also our expert panelists for participating today and sharing their expertise with us. Thank you also to everyone on the network for attending today's ECHO COVID-19 Global Learning Collaborative session. And we hope that you'll join us for the next monthly session. It'll be Monday, December 7th. At the same time, and again, led by Dr. Swaminathan and a panel of international experts. And at that time, we will discuss what we've learned from the global spread of COVID-19. And prior to that session, we are going to have a COVID-19 session on November 30th that I hope you'll also register for. That will be led by Dr. Jeff Katzman, and Dr. Katzman will be discussing managing stress and burnout during the COVID-19 pandemic. So please find links for registration to these sessions in the chat box. And also you'll find a link to the CME survey that you can take to obtain your continuing education credit. So please complete the survey at the link in the chat box. And then watch for email announcements and also visit our website. You will see a link in the chat box to that for more information about these ECHO COVID-19 Global Learning Collaborative sessions. So thank you again, everyone, for your continued commitment to sharing lessons learned. and sharing best practices around COVID-19. And we hope to see you next time. Thank you. Bye.
Thank you. Thank you.
Thank you.
Thank
Bye-bye.
you all. Bye-bye.
Thank you, everyone.